good evening, good night, all of our friends and colleagues from around the world. Thank you for joining us on a special day of the 45-day marathon of webinars and knowledge exchange with a unique, innovative peer-to-peer concept, unlike anything seen in history. We have come together as colleagues and servants of our profession and to bring knowledge and expertise from some of the best and most well-known speakers around the world to our colleagues. Today we have two special guests. We have our host, Dr. Atala, which we introduced 2 days ago, and we have Dr. Prashant Bhasin, a very, very well-known endodontist from India. Thank you, gentlemen, for joining us.
Thank you.
Thank you, Mr. Kinod. Thank you, Tala.
So, gentlemen, just a couple of housekeeping stuff. Today is the day of Mother's Day, so happy Mother's Day to all of our mothers out there that have brought us into this world to put together this amazing operation. Also, on a second note, today we also reached 500,000 of our peers, which will go into history. And thank you guys for joining us on this bright and beautiful day. With that said, I'm going to turn over our host to introduce Dr. Prashant Bhasin, who will bring us some endo love from India.
Hello, everyone. Welcome back. Welcome to our Dental Olympics. So we're back all the way from Israel. We flew back to India, and I'm going to introduce Dr. Prashant Bhasin very quick. Dr. Prashant is a postgraduate from the Department of Conservative Dentistry and Endodontics at Rajiv Gandhi University. Dr. Prashant Bhasin is successfully practiced as a single sitting endodontist and aesthetic dentistry expert in New Delhi. He is also an associated as the professor and head of the Department of Conservative Dentistry and Endodontics in a reputable dental college in Delhi, and is often invited as a guest faculty by various institutions from the United States, Canada, Germany, Dubai, and Brazil, Russia, and Sharjah. Recognized as a well-known speaker at various national and international conferences and seminars, he was contributed many awards, winning articles of his field across multiple platforms. He also holds an international certification on engine-driven endodontics by Essential Dental Seminars at Hodak, New Jersey. He's faculty at Elite
Dr.
Academy.
Tala?
Yes.
Dr. Tala, we have a little technical issue. You might be staging in again. So hang on with the rest of the introduction until we get him back.
So carry on.
No, we are waiting for Doctor to come back online. We've lost him for a second.
Oh, okay.
I'll come back online and chit chat with you a little bit.
So all the way from Israel to India in 2 hours.
So, how's it going over there on your side of the world in California?
I'm on this side of California. You're on the other side of California. So, with all the webinars and everything, everyone is just in the same pool watching the Olympics that you initiated from the beginning. So,
yeah, it's a team effort. Yeah, and it's starting to become a sensational event that can be mimicked by our peers as we grow together. But it's not a one single person operation. It's impossible to do without our peers. It's a peer-to-peer platform, and people have done a tremendous job, as you know.
I love the different perspectives and different angles of seeing things, and we have people not just focusing on implants, but in every aspect as well that is affecting implant dentistry, from surgery to extractions to root canals.
Okay, we have Doctor coming. Just let me go ahead and get Doc back into the stream. Yes.
Yeah, sorry.
All right, let me go ahead and let you guys take over again.
Yeah.
So I'll finish introducing you, Doc, and then we'll be happy to start listening to your lecture. Doctor is also certified in basic and advanced dental implants from Korea, Best Dentist of the Year and Professional Excellence Award in 2015 by the Indian Healthcare Professional Award, awarded with Professional Excellence Award 2015, awarded with Excellence in Conservative Dentistry and Endodontics by the Indian Health Professional Award 2017, awarded with Excellence in Microdentistry Award 2017, first Indian endodontist on international listing of Carl Zeiss speakers in the world, and elected as the Vice President of the Indian Dental Association. He is one of the first honorary member from the India of the 3D Cleaning Group in Italy. Dr. Prashant Bhasin Dental and Implant Center is the first and only authorized training center in microdentistry in Delhi and Carl Zeiss, Germany. Doctor, what an honor. We're happy to have you, and I know that today you're going to be speaking about modern endodontics and in your perspective, so I think everyone is very excited about it. So, welcome.
Well, thank you so much. Thank you so much, Dr. Kinar and my friend Joseph, for introducing me. And it's actually it's a privilege and honor to be here on this forum to share my views and experiences with the august gathering of my colleagues around the globe. And let's go ahead. Let's start. What exactly is waiting for us in the newer perspectives. So that's what I'll be sharing with you all. So can you see my screen?
Doc, can you please add your screen to share the screen so I can add it to the stream?
Just a sec.
Thank you.
So can you see my screen?
It's not in the stream yet. You need to if you click the share screen button, please, and bring it into the webinar room, and then I will be able to put it up.
I've already shared it.
Okay, it's not in the stream right now. So do you want to close it and try it again?
Can you see now?
No, you need to completely close it and share the screen function again, please. And then it will come up in my stream. I don't have it here.
Okay. Just a second.
Take your time.
Yeah.
I would likely completely close the presentation and open it up and then share the screen function, and then we will be able to easily add it.
Give me 2 minutes. I'm just getting my screen on this.
Perfect. I would leave it out of the full screen. There it is. I got it now. Okay, hold on 1 second. Showing the stream, and 2 seconds it will be up. And then we're gonna go ahead and add you the bottom here. All right, doctor. So please. Okay, we lost it again.
Just a second. Can you see my screen?
No, we saw it for a few seconds and then it disappeared completely again.
How is it now?
No, you got to close and start over again. It's not there. It's completely gone.
Okay. I think
So wherever you had
another one.
it, yeah, wherever you had it, it was correct, and then it just suddenly disappeared.
There we go.
There we go. I see it. All right, perfect. We're gonna show this in the stream now. 1, 2, 3 seconds. It'll be up, and then we're gonna click this down here, and you may proceed, doctor.
Okay, thank you so much. So, a very good morning, good afternoon, good evening to all my colleagues and friends around the globe. And as we all know that we are in a state of lockdown and it's a pandemic COVID-19 has been spread all across the globe. So before I start my presentation, I would like to dedicate a small video to all those warriors who have been working day and night for us. So this is a video. Here we go. So just join with me on that.
We'll pick our battles cause we know we're gonna win the war. Win the war. We're not rattled cause we shattered all of this before. Steadier than steel cause we're ready with a shield and sword. Back on the saddle cause we've gathered all our strength for more. And we won't bow, we won't break. No, we're not afraid to do whatever it takes. We'll never bow, we'll never break. Cause we are warriors, we'll fight for our lives like soldiers. On through the night and we won't give up. We will survive, we are warriors. And we're stronger, that's why we're alive. We will conquer, time after time, we'll never falter. We will survive, we are warriors. We are warriors.
Dedicated to you. This video is dedicated, this presentation, to all the warriors from my family to yours. Jai Hind. So let's move forward. So before I move forward, I would like to first acknowledge and pay my gratitude to Global Interdisciplinary Summit, which is actually an Olympics, which we are actually going on. If you can see that, I'm really so honored that to be a part of this interdisciplinary summit, which has actually grouped together all the top 100 clinicians, academicians across the globe, and which have come together under the umbrella of GIS to share their views and experiences. So I would like to thank the entire team who has been working day and night, and hope in the coming times we will take it to the next level of excellence. So let's move forward for the topic of the day. So modern endodontics, the newer perspectives. That is what I would like to share with you all today in my presentation. So let's unfold the journey of modern endodontics. Now, before we go ahead with the journey of modern endodontics, there are certain concepts that we need to keep in mind. To start with, number one is the conservation of the structural dentine, followed by the modern instruments. Magnification is changing the world of endodontics that what we have been seeing. 3D cleaning, that means we have to clean our root canals three-dimensionally, followed by the three-dimensional sealing of the endodontic spaces. Last but not the least is the healing of the periapical lesion, and followed by the microsurgeries. Now, before we go ahead for the newer perspectives, there are certain considerations that we should keep in our mind. Now, what are that? To start with, we need to have a good accessibility of the tooth before we take up that tooth for the endodontic procedures. And we need to also see for the restorability of the tooth, followed by the checking of the periodontal status of that tooth, so that we can understand that what type of treatment is being needed. Unusual length of the teeth depending upon the radiographs what we are looking at, and they will also help us to look into the unusual canal shapes. Again, thanks to world of magnification, that we have now can see more number of canals which are already there. But yes, when you have a good access to those areas, I think you can create wonderful results for your patients. We should look for the resorptions, and if they are there, then definitely the choice of materials is the MTA. A lot of calcifications we had been seeing in our routine dental practices, and I feel that ultrasonics are the game changers for it. Most of the canals are being blocked because of the broken instruments and ledges, and we should, and thanks to world of magnification ultrasonics, that we are able to bypass those ledges, and we are able to bypass those instruments, and along with that we are able to retrieve those instruments. And last but not the least are the perforations. So if we have some perforations happening on our teeth, whether it's on the different aspects, then the choice of material is an MT or a biodentine. But before we go ahead, there are certain factors for the treatment planning that we actually keep in our mind. So, what are that? So, number one, we need to have a good clinical and a radiographic evaluation of a tooth, followed by the endodontic evaluation, then by the periodontal evaluation, followed by the drug history. Now, as we all know that COVID-19 is pandemic, right? It is like spread all across the globe, and especially those patients who are having an underlying lung disease. So please be cautious when you're prescribing those anti-inflammatories to them. Then definitely look for the good canal, assess the architecture, followed by the vitality of the tooth. I feel the vitality of the tooth will be the another game changer in the coming, because the entire perspective of the endodontic treatment will change after COVID-19. Definitely we have to think ahead of time, and definitely if you have a vital tooth, the single sitting endodontics will be the future, followed by the periodontal involvement. So again, the treatment has to be planned. And I always say, do not prescribe antibiotics and analgesics if it's not needed. And the best way is to actually give 5 minutes to your patient so that you can listen to his chief complaint and plan a proper treatment for him. So there is a very good article which I would like to share with you, and which is given in the International Endodontic Journal in the year 2017, which actually is a very good article to know about the indications and the contraindications about the antibiotics and anti-inflammatories in our endodontic procedures. So you can go to this article and have a look into it. So let's move further. So what are the number one, what we'll talk about today is this, like we can preserve the structural dentine of the tooth. So I had a privilege to work with Dr. Allen and Dr. Berry in United States. It's been quite some time, and this is one article which is actually an amazing article for all of us. We all are practicing endodontics, isn't it, in our routine dental practices? But what is the main problem? What we are facing is that we are not able to get inside the tooth, especially when it is a calcified chamber. So again, if you follow this formula, that the mean distance E, that is E, from the cusp tip to the roof of the pulp chamber, for a mandibular molar it is 6.36, and for a maxillary molar it is 6.24. So let's take it as 6.5. So that means once you have entered inside the tooth about 6.5 millimeters, that means you have entered inside the chamber of the tooth. So that is the first thing that we should keep in mind. And during that, once you have entered the tooth, then your ultrasonic should move in, and then you should refine the cavity accordingly. So the major advantage what you will feel here is that you will tend to avoid any kind of perforations happening at the floor of the root canals. So that is where exactly the most of the perforations happen, because we keep on drilling and drilling inside the tooth structure, and we keep on weakening the internal anatomy and the external anatomy. So this is one formula which you can apply in your clinical practice, with which you can have results which are much more predictable. Now, most of the teeth what we have been treating in our practices, they do have a well developed cusp, right? But definitely we get those teeth in which they are attrited or the cusps are gone. So in such cases, this formula will not work. So in those cases, the cemento enamel junction will act as a guide to determine the depth of the burr during penetration. So the best way that you can do is that you can put a rubber stopper on the burr, and then you can measure on the radiograph before you enter inside the tooth structure. So this way, what will happen is that you are in a controlled area of working. So once you have a controlled area of working, then definitely the chances of mishaps in endodontics are very less. Now, As we all, I think all of us are practicing endodontics and dentistry, like I think every day, right? But it's a lockdown. So I think this is the one picture which I would like to share with you all. This is the way that we practice in our dentistry, isn't it? Right? And I think most of us are practicing about 8 hours in a day, morning I think from 9 to 1 o'clock, and then evening from 5 to 8 o'clock. And this is the position in which we are working. Again, please remember, we all are one man army, and the COVID-19, we have the most closest contact with the patient as the dentist. So if we are still working in this kind of positions, that means we are actually getting trying we can get infected, number one. Number two, we are actually spoiling our ergonomics. If you see here, by bending so much on the tooth, what we are earning is the money. The answer is not that. You are definitely earning a money, but you are losing on your ergonomics. So what I suggest that you start changing the way of your working. So the best way is that add magnification to your practices. That is the best way to do it, because that gives you a working distance between you and the patient, number one. And definitely with the addition of rubber dams in your practices, this will actually change the entire concept of working in endodontics with us. So dental loops is one thing which I always recommend that you should use it. And the second thing that you the best to be used is a microscope. I have been working with microscopes in the last so many years, and what I have realized during this COVID-19, especially, that the working distance what I am getting from my patient and towards me is about to 250 millimeters, and that's where exactly I am mostly safeguarded myself. So again, if you add little bit of magnification to your practices, I think we will try to practice much for a longer period of time, and definitely we will practice in a much safer zone. So this is your choice now. You want to practice like this after COVID-19, or you want to practice like this. So the choice is yours. And please remember, again, as I said, we are one man army. And that's what we are looking at. The day we are out of this world, everybody forgets us. So please remember, stay safe. Start working in a very ethical form and in a very ergonomical form. Now, as we go further, the magnification doesn't start from a microscope or a loop, but definitely we need a good mirrors to look into it, right? So if you see here, if you have a mirror which has a less reflection of light back to you, say about 60%, then how you will going to see the inside of the root canals? So my suggestion to you is that you start using mirrors which have a high refractive index up to about 95% of light. So accordingly, that will help you to have a better depth of field inside the root canals. So again, the answer is the more you see well, the more you treat well. Now, the beauty of magnification is that it actually helps you to differentiate between the texture and the color of the tooth inside. If you see here, this is a calcified area. This is actually the you can see the orifice of a calcified canal, right? So once you have a magnification with you, these kind of areas can easily be explored in a much better form, because it will help you to differentiate between the texture and the color of the calcification from rest of the floor. Secondly, what it gives us a very good depth of field. Now that is one of the key features in endodontics that we need to see deeper inside the root canals, so that we can actually explore all the minute things which are there, right? So again, magnification will going to change that world. Now, if you see here, this patient, if I share with you, this is a case, a patient had an all ceramic crown, which was vital, right? And the patient kept on complaining of a sensitivity, of a hot and cold sensation. So definitely the choice of treatment left over is an endodontic procedure. And in today's time, if I ask somebody to actually change the all ceramic crown, it's like a nightmare for him, isn't it? Don't you think so? So what we should do? So again, if I have a magnification, and if you see the kind of access design what we have prepared, and with that we have gone inside the tooth canal, inside the tooth, and we have completed an endodontic procedure. Now the beauty of magnification, what has helped me here in such kind of cases: number one, a minimal preparation of the coronal aspect, and secondly, I get a depth of field with which I can also see the middle mesial canal. So again, a conservative design which is acceptable for an endodontic treatment, followed by a good depth of field, will be the game changer in endodontics. Another case, if you see here, middle mesial canals, right? Again, the world of magnification is helping us to explore these unexplored areas in the field of endodontics. And that you can see here. This is a medial mesial canal, which is being prepared by the rotary endodontics, and the middle mesial canal I try to prepare with hand instruments. Because in most of the times, if we talk about the science of endodontics, the middle mesial canals, they become confluent either with mostly with the mesiobuccal canal or with the mesiolingual canal. It is very rare it has a separate portal of exit. So here you can see a microscopic view of the middle mesial canal orifice. So again, if you have magnification on your eyes, I think you can see better inside the endodontic procedures, and that is what the world is looking for. Now, moving from magnification, the another aspect, which is another a very critical aspect in endodontics, will be the introduction of ultrasonics in the field of endodontics. Yes, ultrasonics are the next game changers under the modern endodontic concepts. Now, what are they helpful for? Number one, actually for the axis refinement, finding of the calcified canals, removal of the attached pulp stones, again removal of the intracanal obstructions, for the agitation of the irrigating solution so that we can increase the molecular energy of that materials, ultrasonic condensation of the gutta percha, placement of the mineral trioxide aggregate, and last but not the least, on root end preparation. So these are the various ways that you can use ultrasonics in the field of endodontics. So there are different tips which have been available with us, with which you can actually do these kind of treatment procedures. But the one thing which I would like to share with you all, that whenever you are going to go for a good ultrasonic tips, it should have a water supply through the tip. Now, again, that is important because most of the ultrasonic tips what we have been using has to be used under dry conditions, right? So again, when you're using an ultrasonic tip, especially for the axis refinement or for the negotiation of the pulp stone or for the removal of the broken instruments, so the main thing what you need to understand is that it should be kept in a dry condition. Now the other thing what it causes is a heat generation inside the tooth. So if you have a portal of an irrigation through the tip, that will keep the tip cooler, and also it will maintain the temperature of the tooth, so there won't be any unnecessarily heating of the tooth structure. And again, when you are defining such kind of cavities, the access cavity, then you should have a diamond coated tips which gives you a much more conservative access design. The different types of tips which I've been using in my practices, that you can see, it is a CPR tips for the retreatment, then you have Buchanan tips for the axis refinement, and then definitely we have a microsurgical tips for the microsurgery, which I'll be sharing the cases when I move forward. Now, there are the different types of tips which I've been using in my practice for the retreatment. So the choice is yours. So this is what I've been using in my practice, and I'm very much happy with this. And you can try as per your need and as per your design, because all the tips have a different function. So some may be used for the axis refinements. These are the titanium tips which has a mono block. So again, that will take care of your deeper areas of the root canal. Then we have some axis refinement tips. As you can see, the different sizes for different purposes, like this is for the you can say refinement of the axis. Then again, this is for the smoothing of your pulp chamber, right? So different tips have different functions. So let me share you a case that you can see here. A lower molar, axis opening done, and then followed by the refinement with the ultrasonic tips. Again, you can see a more conservative access design with the maintenance of dentine all around, followed by the glide path. The watch winding is a key to glide path, followed by the irrigation and activation of the endodontic irrigant. Clean chambers, activation, use of ultrasonics, cleaner canals, and there you can see results which are predictable, more conservative, followed by the orifice axis opening. You can see the orifice shaping. There you can see, and the shaping of the isthmus. clean canals, the glide path with rotaries now, and then followed by the rotaries to prepare the entire root canal. A step-by-step protocol to do the entire biomechanical preparations, what I'm trying to show you here. Now, in case you're doing a multiple visit endodontics, then definitely we need to close it down with a interim restoration, right? So make sure that the interim restoration has a height of 4 millimeters when you're placing them. Other types of tips what we have been using in a modern endodontic concept are the microsurgical tips. Now the beauty of these tips is that you have the irrigation portal right at the tip of the tip. That is the beauty of it. That means because once we are doing a retrograde preparations of our cavity during the endodontic retreatment procedures for the placement of the mineral dioxide aggregate, then in such cases the microsurgical tips are the game changer, because it has, if you see here, it has 1, 2 and 3 shaft, and you have 3 angles. So the more angulated tip it is, so the better access under the microscope you can get it to prepare those retrograde cavities. And there you can see that under the magnification, the placement of the the microsurgical tips, and there you can see the retrograde cavity which is being prepared. So again, results which are more conservative and predictable. The next concept is of the 3D cleaning. The next newer concept is 3D cleaning. That's a project I see, and I'm honored to be the part of it. And let me share what exactly the 3D cleaning means to us as an endodontist. As you see here, the anatomy of the tooth is very varied, right? If you see here, you have isthmuses, you have apical deltas, you have different morphological variations inside the tooth. Okay, so please remember that when you're working in an endodontics, that the endodontic procedure mostly will be taken care not only by the rotary files or the hand files. The one of the major part of the root canals will be cleaned by the endodontic irrigants, because such kind of intricacies which are being there, like apical deltas and the isthmuses, you need to irrigate and activate the endodontic irrigants to the core, so that you can clean those areas in a much effective way. And there you can see here, there you can see this is thanks to my friend Dr. Alfredo Indialo from Italy, who has shared me this is absolute work to showcase with you all. And here you can see here, you can see what are the different isthmuses are there at the apical end where the dye preparation, you can look into it. And then there you can see there are multiple foramens which has been there. So all these need to be cleaned well, so that we seal those areas well with the obturation, so that there is no chances of the reinfection in those areas. And there you can see the multiple portal of exits which are being cleaned well and sealed well, right? So again, irrigation is needed to clean these areas in a much better form, and that can only be done with the activation of an endodontic irrigant and also with the internal heating. That is the two concept that we really need to inculcate in our practices, so that we can clean this apical 1/3 in a much better way. Now let me share you a case. This is a case of an upper maxillary molar where you can see, and this is what you can see under magnification is actually the activation of an endodontic irrigant with the internal heating, right? So they are the two things what we need to do during the endodontic concepts, that we need to activate a irrigant. Now the question comes is how long we should activate. A minimum of 30 seconds to 1 minute. Every irrigant should be activated every time when it is introduced inside the root canal. I again repeat, 30 seconds to 1 minute. Every irrigant, every time. So once you do that, again, what type of needles you should use when you are doing irrigation. So again, if you're using this kind of irrigation, please stop doing in your practices. So what you need is a drop by drop irrigation, and for that the best indicated needles are the side vented needles or the double vented needles or the laser indented needles. So they will help you to actually know inside the root canal how you are doing it. Now, there are different methods of activation of an endodontic irrigant. So if we see here, we have a manual and also we have a machine assisted. So in terms of manuals, we have side vented needles as I shared with you before. Then we have some brushes like an endo brush or a navy tips. Then we can do a manual dynamic agitation with the help of a gutta percha. But if you go to the machine assisted, then I feel the ultrasonics, again, activation of the irrigant with an ultrasonic is actually one of the major areas that will change the 3D irrigation protocols for us. Now, the different things which I've been using, these are the some of the systems what I'm using in my practice. And again, thanks to my friend Alfredo from Italy for sharing me this video of him. It's an amazing one. If you see here, there's a periapical lesion, right? So what we will do first, once we have done the access opening, we'll place the endodontic irrigant, and then once it is being placed, we should first heat it up. So you have pluggers, you can heat up the plugger and go and increase the molecular capacity of the endodontic irrigant. We have to increase the molecular energy. Now once you have increased that, then you follow it and add it with the ultrasonic. So if you see here at the apical 1/3, it will help in a better penetration inside the dentinal tubules and also better cleaning of the dentinal tubules. Followed by a three-dimensional obturation, which will help in healing of these periapical lesions. And that is where we are looking into the world. And that is how the world is changing now. So this is how exactly, if you can look inside the tooth, how the ultrasonic irrigation actually works. Placement of the endodontic irrigant, there you can see. And then placement of the endodontic activators. So there are different endodontic activators which are available with us in the market. So the choice is yours, right? So choose an activator which is good enough. And there you can see the activation of an endodontic irrigant. The more you activate, the better, cleaner the canals will be. So that's the key. Again, once you're activating, you see, you need to replenish every time when you're putting the endodontic irrigant inside and activating it. So the more you put, the more you replenish and the more you activate. Again, as I said, 30 seconds to 1 minute is the irrigation time that we need to spend on the tooth. That will be the another like lead to the success in endodontics for us. Keep doing it till the results are predictable. And once that has been done, you can see the clean chambers, the clean orifice, the complete removal of the pulp tissue, and yes, the results which are appreciable. And this you can see under the higher magnification under the microscope that this canals orifice are look like valleys because they are being cleaned well, shaped well. That is what we are looking at. The more you see well, the more you treat well. That is where the world of magnification is there. Followed by the obturation. Again, now one point which I would like to share with you all, that once you have done the obturation, so the choice of obturation is with you, that the cold lateral or the warm vertical. But again, when you have done the obturation, please ensure that the entire sealer and rest of the obturating material should be completely removed from the access openings, because there is a tendency sometimes that we have a tendency to leave some kind of a sealer, right? So please don't do that. But again, if you have a magnification on your eyes, you will be able to see well, then definitely you will be able to clean those areas in a much better form. That's the key. Now once that you have done that, the idea is once it is clean, then it will have a better bonding of your restorative material with the tooth structure. So the better bonding, that means the better stability of the tooth structure, and the tooth structure will last longer for us. And there you can see, with the help of endodontic irrigation, ultrasonic activation, and internal heating, a three-dimensional cleaning of the root canal system will actually help you in a three-dimensional obturation of the same root canal system. And that is what we are looking at as a specialist, as an endodontist. Now, another thing what we need to understand when we are doing an endodontic tooth preparations inside the access design is that, please remember that what we look inside the tooth from the top and what we when we go inside the tooth, it is altogether different. Again, when you're working inside the tooth, please ensure that the most of your preparations what you're doing with the endodontic files should be more on the outer surface of the root canal walls rather than on the inner surface. Why? Because we have a less dentine on these surfaces. Again, and definitely we have more concavities present in molars and the premolars. So if you do a lot of endodontic root canal rotary preparations on the inner walls of the root canal, then the chances of strip perforations are much higher. So again, please keep that point in your considerations when you're using your rotary files inside the root canals. And again, as the chances of MB2 canals are much higher, again, almost about say 90 to 95% of the upper maxillary first molars, they do have an MB1 and an MB2 canals. But yes, as per the literature, we need to understand one thing, that an optimally clean and a shaped MB2 must be prepared more conservatively than an MB1. Because if you do an over preparation of an MB2 canal, then there is an increased chances of the fractures or the strip perforations of that area is there. So again, when you have those MB1s and MB2 inside the root canals, please ensure that you prepare the MB1. And most of the time, what happens, as per the Dr. Bertucci's classification, we have different classification. So again, keeping that in mind, but most of the time MB2 is coinciding with the MB1. So when you have such kind of teeth with you, then again, please try to prepare more conservatively the MB2 and prepare better the MB1 with the good irrigation protocols. That's the key what we are looking into. And that is how you can see here a more conservative, and we have actually not increased the access design a lot, because the MB2s are generally found in a line joining the MB1 canal to the palatal canal. So that means it can be 3 millimeters away from MB1, and it can also be 3 millimeters below the floor. So again, when you are troughing with ultrasonic tips, so be sure that you are troughing in that safe zone area, because there are chances that there may be a variation in the presence of MB2 inside those root canals. So go slow, but go steady, but use ultrasonics in a dry condition so that you can stuff it well. Once the debris is collected, irrigate, clean it well, and then again see where you are and try to explore those areas. Let me show you how exactly it is. If this is a case, you can see the upper maxillary molar, a completely calcified chamber, and with the help of ultrasonics, you can see the presence of an MB2. So again, ultrasonics will help you in a more controlled preparation of your root canal systems. Please remember that. If you use birds here, most of the time we have a tendency sometimes that we can use a bird in this area. There are different types of birds available. But again, birds, they have a very high speed. Okay. So again, if you use ultrasonics, ultrasonics will have a speed which is under your control. Okay. You can increase the speed. Always start the ultrasonic from a slow speed, and then keep on increasing the speed as you go and you need to trough in those areas. Same thing goes with our lower anteriors, right? Again, these lower anteriors, they mostly now 40% of the lower anteriors have about two canals. Now, if you talk about the lower mandibular incisors, they generally have 40 to 45%, and also the canines. So in such kind of cases, what you need to do is that you need to design your access much more incisively if you have to locate for the second canal in the lower anteriors. And this is how you can see that. You can see in this illustration that how with the help of a round burr that we have got to the pulp horn, and then what we can do is we can take an ultrasonic and we can just refine that area above the pulp horn, so that we can get access to both the buccal and the lingual canal of a lower anterior. And here you can see that this is a case of a lower anterior which reported to me, right? Patient looks fine, then suddenly after some time it developed a periapical infection. So again, it was referred to me back by one of my colleagues. I opened it up, and what I did, I placed that calcium hydroxide inside the root canals. I sealed it up for about 6 weeks, and then I waited and see. I went again. If you see, it looks like a one canal, but yes, you see the change, how exactly it is happening. This is not one canal, it is actually the two canals. Again, thanks to world of magnification and the anatomy of the tooth. Again, how as a clinician, if you're not using magnification, you can rule out, okay, that this tooth may have a second canal. So the best way is that, as we say, a fat man have thin legs. Yes, a fat man will have thin legs. So the same thing, start looking to your lower anterior teeth in a buccolingual aspect. If the buccolingual thickness of a tooth buccolingually is thicker, that means it is broader, please start thinking the presence of a second canal is there. But yes, if you have a magnification on the top of it, the results will be far amazing what you are thinking of. Another thing in newer concept what we look at is the endodontic retreatment, right? So if you see this case, if you see here, the upper maxillary molar looks fine, right? But the patient kept on complaining of pain and tenderness to percussion. And we can see a development of a small periapical radiolucency in the MB1. So what I did, I opened up this case, went inside, used a long shank round burr, removed the coronal gutta percha, and then with the help of the GPR kits, what I've been using in my practices, I removed the entire gutta percha, and then I went inside the root canal with my different types of files which I've been using in my practice for bypassing that calcified area, and then we have cleaned them well with the hand instruments and the rotaries, and then followed by the obturation. And there you can see the 3D cleaning helps you to actually fill up those lateral canals at the apical one third. So again, if you have magnification in such kind of cases, these kind of results are much more achievable with us. And then we have been sealed with the help of a resin sealers. Another very important aspect which I would like to share with you, that sometimes we are not able to actually diagnose that a problem inside the tooth is actually because of the endodontic origin, or it is because of the periodontal origin, right? So if you have a periodontal stator, you should start first with the depth of probing, and you should see. Now, if you have a wide periodontal pocket, please be with me. If you have a wide periodontal pocket, that means the failure is happening because of the periodontal origin. But if you have a narrow probing pocket with a single point probing, that means the problem is in the tooth is because of the endodontic origin. So that is where exactly we need to think, and we need to diagnose our case in a very stringent form, so that we can actually render a proper treatment to my patient. Because sometimes what happens, you are in a confusion that it is a primary endodontic lesion, or it's a primary periodontal lesion, or it's a combination. So there are different classifications which has been given by Cohen. Again, those classifications, if you are keeping in your mind, and accordingly if we go as a clinician, this is the best clinical tip that you can look for. The second thing what you should look for is the vitality of the tooth. If the tooth is vital and then it has a pocket, that means the chances is most because of the periodontal origin. But in cases of the endodontic problems, the tooth is, in most of the cases, it is non-vital. So these are the two clinical tips. If you apply in your practices, I think you will able to bypass those kind of complications in the future. And this you can see here, this is a case of a lower molar which had actually a periapical abscess. Okay, if you see, there's hardly any bone loss in the furcation area, right? But it has a deep pocket, right? But it has a single point probing. So what we did, we opened it up, cleaned that entire area, irrigated it well, followed all the protocols, and then placement of the calcium hydroxide inside the root canal. Now here I would like to insist that when you have a periapical lesion, then in such cases the medicament for choice is and calcium hydroxide with iodoform. So once that is placed inside the root canal, it actually gives a vehicle for the material to move in, and definitely it helps you to actually sterilize, or you can say disinfect that area in a much better form. And there you can see after 1 year post-operative follow-up, and you can see the middle mesial canal right here in the center of the tooth, right? And then followed by the obturation. After the 1 year we did the obturation, followed by the 1 year 6 month follow-up, we can see healing coming in. Again, the protocols of three-dimensional cleaning, all the protocols have been formed, activation, placement of the intercanal medicament, and finally in 3 years we can see the complete healing with the complete bony infill. So again, if we have to wait for such kind of cases, it takes time. See, the radiographic changes in a periapical lesions don't come so soon. It can take about 6 months to 1 year to 3 years to come to almost somewhere around 5 years. And the beauty is that you can see even the middle mesial canals. So again, magnification, good irrigation protocols, following the protocols, and getting the things right on the track, I think the results will be far more predictable. Another problem what we face in our dental practices is the calcified canals, right? So again, either there is a loose canal or a tight canal or a really tight canal. So again, there are different types of file systems which has been available with us to bypass those files. But again, there are different available. Definders are one of them which I have been using in my practices since quite some time, which is actually a game changer with time, right? So here it is a video which I would like to share. It's a very important video, and which I would like to share with you, that how they differ from your normal K files that we need to see here. So if you see this D finder, it actually has a very different design than a normal K file. This video is important so that I can differentiate between a normal file and a specific file for the calcified canals. So the D finder gives you an unprecedented blade with a smooth insertion and efficient canal preparation, which is not available with us with the K files actually, to be frank. So what happens when you go inside the root canals with your normal K files, especially when it is calcified, then what happens? When you go in, it actually buckles up. And then what we are doing? We are taking the new file. So we need to have a stainless steel file which is strong enough to actually go inside the root canal and bypass this calcification in a much smoother form. This you can see a K file, it goes, it resists. And then when you pull it out, it is again all distorted. And what you are doing, again, another new K file, right? So again, we have to think economically. So the next solution what you have is a D-finder, which actually you go in a watch winding motion. Because of the cross section, it helps you to bypass those calcified areas just like a snake. And it is available in different sizes. So when we have such kind of teeth which are calcified, so we need some intermediate sizes to actually do that. Let me show you a case. This is a case of an upper central incisor which is calcified. And now this is the different burrs which we have been using in our practices for getting inside the root canals. And this is the placement of the burr with the radio. You can see there under magnification. And this you can see a complete calcified chamber, right? So what you do, you place this burr inside the root canal. Okay, this is an endoguide burr. You place it inside the root canal, and then we take a radiograph. And now the beauty of this burr is this is known as an orifice directed burr. So especially in those kind of cases where we have actually a calcified tooth. So in such cases, these kind of burrs and files will be actually the different altogether to help us to negotiate those areas in a much better form. That is the beauty of that you can see here. So once you place it, you take a radiograph, so it will help you to orient the burr. You will able to orient the burr properly, that yes, this is my canal path. And now once you have got to that path, you can take the files which are you are using in your practices, and you just bypass and go inside the root canals. So we have to make dentistry and endodontics much more easier with time. Another case which I would like to share you is the removal of the use of ultrasonics for the removal of the threaded post from the root canal, right? So here you can see, this is a case of a threaded post inside the root canal, which is, it's a threaded post which a patient had, and the patient developed a periapical lesion. So we need to remove it, right? So again, the choice is ultrasonics. So whenever you are using these ultrasonics, you need to trough around the post, but make sure if it is a threaded post, then you have to be careful, because if you touch more of the post, the spirals of the post, then they get distorted, and there are chances of fracturing of this post inside the root canal, right? So what you can do is, once you do that, and then you go on and on. So you go in a clockwise direction. It is so that it keeps out, because it's a threaded post. So it goes in a clockwise in, but when you have to take it out, it will come anti-clockwise. And there you can see that. The idea is the post, we want to remove it in a much easier without fracturing. And there you can see that. And there you can see the complete post is out. So we started in a slow speed under the dry conditions, so that we know where exactly we are troughing. Now once you have done that, then there is an underlying gutta percha, right? So I need to remove that also. So again, removal of the gutta percha from that area. And there you can see under magnification, you can see the apical 1/3 of the gutta percha. There you can see inside, this is the gutta percha, the depth of field. The beauty of these Zeiss microscope, what I've been using in our practice, is that it gives you a very good optics. So again, I can see better inside my root canals, and then I use my GPR kits to remove those gutta percha from the root canal. There you can see that. And now once that has been done, and now you can see the clean root canal. That is complete elimination of the gutta percha from the root canal. So once that is been done, then finally what I will do, I will place my intracanal medicament, that is a calcium hydroxide, inside the root canals, and I can get my results which are promising. And there you can see that the placement of the calcium hydroxide inside the root canals, so that at least I can sterilize my root canals. Definitely in between we have done our irrigation protocols, so that we can clean the entire debris which is being present inside the root canals. And finally we clean it, and then we place the intracanal medicament for at least up to 6 weeks. so that the whatever the lesion of it, whatever the we get to clean the entire, we have to make the entire area sterile for the final obturation. So again, results which are much more predictable. Again, removal of broken instruments. Again, how we can do with that. So again, we have been using a lot of equipments in our practices, like different types of kits are available. But again, one of the game changers in the endodontic broken instrument retrieval is U files, what I've been using in my practice. This is a more economical way to do it. But again, I strictly say when you are trying to do a broken instrument retrieval under the magnification, please understand you have to have a magnification if you attempt the removal of broken instrument. See, every instrument cannot be retrieved, right? So again, it depends where it has broken, whether it is in the coronal third, middle, or the apical third. So if you are at the coronal third, the removal is much more easier. You don't need a microscope. Even with the help of loops, you can do it. But if it is in the middle third, it depends whether it is above the curvature or it is below the curvature. So if it is below the curvature, then we have to actually make a staging platform so that we are able to see the tip of that instrument before we retrieve it. And then you can see that. Now, once you have the straight line, you need to have a straight line access to that instrument. That is the important area. If you don't have a straight line access to that instrument, then the chances of removal of instrument is much lesser. So what you need to do is, in such kind of cases, you try to bypass that instrument, right? So if you're not able to remove, then the bypassing is done. Now, when you have to plan a bypassing of the endodontic instrument, a broken instrument, please bypass it along with the inner wall of the root canal. That is the key to bypass the broken instrument, because most of the time, what happens is our endodontic rotary instruments, they fracture in a 360 degrees. So that means they are rotating in 360 degrees and they are cutting. So they engage into the dentine on the outer wall and they break. So that means the instrument is actually at the outer wall, but not on the inner wall. So you have a space with the help of the files that first you go on the higher side, go with the larger number files so that you get that nick where you get the catch point. First go watch winding inside, you get the nick. Once you get the nick, then you go in and out. Okay. Again, I repeat, first you go watch winding till the nick that you get a catch point near the instrument. Okay, this is where exactly I am. And then you keep hitting so that you bypass that instrument with the help of the hand files. Once you have done that, then once you get the area clean through that, then you can use the ultrasonics and you can go beyond and agitate that ultrasonic, which will help you to retrieve this file outside the root canal. And this we're going to see now. You can see here, I'm going along with the inner wall of the root canal with my ultrasonic tape, and I'm trying to loosen up my instrument. Again, you can see these are the long tips which are diamond coated tips which are there. So I'm toughing on the inner wall of the root canal so that I can make my instrument loose. There you can see that. Again, I'm more towards the inner wall, going and going inside. I really want this instrument to be retrieved. So again, the magnification with ultrasonics are actually the newer perspectives, which is changing the entire the perspective of the endodontic treatment and the retreatment, what I say. And then you can see that. Keep on going. Keep on going. Go again along the inner wall of the root canal so that you can retrieve it in a much better form. And there you can see it. But be careful that you go slow. Do it on a slow speed. Again, keep going. The more you go slower, then you can increase the speed depending upon how much it is being needed. And there you can see that. So these are the different sizes what is been happening. Still it is there, right? You can see that the shiny spot which is there. This is a tip of that broken instrument. And let me go a little more inside. So there we go, and it starts jumping. See here, and anytime it can be out. So go in and out. Again, go clock, and there it goes. And you can see that the instrument is out. Now, one point which I would like to share with you all here is, when you're attempting a broken instrument retrieval, I had a nightmare when I started my practice with the retreatments. I was trying to retrieve a broken file. Okay, and what happened? The instrument retrieved, it came out and it jumped into the neck, into the another canal. So again, I have to spend more time. So please, one recommendation or one suggestion: whenever you are attempting a retrieval of a broken instrument, please block the rest of the canals with the cotton or with the gauze or with the paper points, so that you should not face those problems. See, when we face the problems by ourselves, then we are able to tell you the solutions. That is the best way to do it. And there you can see the complete wall, and you can see the inside of the root canal. It is maintaining the enough dentine so that we have not created any perforations inside. So that's the beauty of magnification and ultrasonics. It helps you to achieve results which are predictable. Let me share you a clinical case on this. You can see a broken instrument in the lower molar, right? We went inside the root canal. We can see the tip of that instrument, created a staging platform to that, right? And then we started. If you see here, I started toughing along the inner wall of the root canal, and there you can see the inside view of the broken file. This is the tip of the broken file under the microscope, which helps you to see that this is actually the inner wall of the root canal and this is the outer wall. So again, we have trough more on the inner wall so that we make the instrument much more looser, and finally the instrument is out, and then final obturation which is being done. So again, you have different materials, different kits for you to use them in your practices and get results which are much more predictable. Next comes the healing of the periapical lesion. This is another very important concepts which we need to discuss more on that. So this is another case how it can see. This was a patient which got an implant done, and then he developed a periapical infection with the premolar. Right. If you see the close proximity of the implant which was there, right. So it was referred to us, and the patient developed a periapical lesion, right, because there was a breach in the continuity of the lamina dura. Okay, no worries. We opened it up. Sorry, we opened it up, placement of the intracanal medicament inside the root canal. There you can see placement is done. I want this lesion to heal. Being an implantologist as well, I always want a good bone for my implants, right? And especially if I have a tooth next to it, please ensure. This is my one suggestion to you all, that if you're practicing implantology and you have a tooth next to the implant which is infected, please don't go and place an implant first. First, treat that tooth, because you need to create a healthy environment even for the implant to be there. Because when we see a radiograph, the periapical lesions, what it looks on a radiograph, it's a two-dimensional view, right? But you need to think as a three-dimensional. So that means what you see on a radiograph, it will be three-dimensional larger than what exactly you can think about. So in such cases, first, definitely is better to treat that tooth, place the intracanal medicament, let the lesion heal. Okay, once it started healing, and then 4 months follow up, and then finally we obturated then, and finally you can see the results with the complete bony infill and again healing of the periapical lesion, and the implants are surviving. So again, we are here to work both as a team. So again, then is the only way that you can get results which are predictable. Again, the different choice of materials in my practice is what I've been using. Another one more aspect which I like to share with you all is that when you have a calcified tooth with a periapical lesion, that means there is a canal. Yes, again, in such kind of cases, CBCT will be the next game changer for us, because it will help us in diagnosing in these cases more well. But again, I said, if do we really need a CBCT for this? If we have a magnification in our practices, I feel that will be a better view, because it will give you a more depth of field inside. So this is what it has helped us. With the help of magnification, we have went inside the root canal, did that 3D irrigation, 3D cleaning, internal heating, and placement of the intracanal medicament, and you can see the lateral canals which are being filled up beautifully. And again, you can see the results which are much more predictable. So again, if you follow the protocols in endodontics, you can get those amazing results with you all. Another case, you can see this is a case again with the implant. There was a tooth, right, and it developed a periapical infection. But in this case, implant is beautifully placed, right? But what has happened? The earlier colleague of mine, they must have missed the canal, right? Again, thanks to world of magnification, we opened it up and we are able to scout that canal again, right? You can see the canal is being scouted, prepared, placement of the intracanal medicament, and then finally the healing. Again, the results which are much more predictable and achievable. So that's what we are looking at. Again, an endodontic retreatment. The patient was undergoing an orthodontic treatment to some practice. It was came to my practice, and what we saw, there was already a root canal treated teeth which developed a periapical infection. We opened it up through the crown, placement of the intracanal medicament, that is a calcium hydroxide with the iodoform, what is being placed inside for about 4 to 6 weeks. and then we can see the healing. And then what I did, I now in such kind of cases, I have changed my protocols of working as a clinician. Now what I'm doing in such kind of cases is, once I have placed the calcium hydroxide and I see the healing which is happening, and I see that there is no exudate or there is no abscess discharge coming through the canal, my choice of material here will not be now a gutta percha. Now it will be the MTA, because I want to reinforce my tooth structure so that I can actually make this tooth long lasting. Because again, if you see here, we have filled it the entire tooth with the MTA. I don't use gutta percha here. And then you can see here the 3 year follow up, the healing again, to which is again predictable. So again, if you use some kind of an osteoinductive material inside the open apex cases or inside your resorption cases or where you do apical dissections, my choice of material is always an MTA, so that I can seal a three-dimensional root canal system. Because once I seal it three-dimensionally, I have the chances of success with me, and that is what we are looking at. As I said earlier, open apex, again another important area which I would like to share with you on this. If you see here, now this is a case of an upper maxillary central incisor with an open apex, right? So in such kind of cases, the treatment of choice, what you should do, you are not supposed to prepare these canals a lot. God has been very kind to us in such kind of cases. Remember that the canal is little unparalleled. Okay, we need only finishing files to just straighten up these walls. Because as I said earlier, as an endodontist, the concept of newer endodontics is to preserve the coronal dentine and also to preserve the radicular dentine. And if you do that, then only the results will be with you. Okay. So what we do, we prepare these canals just with the finishing files, and then I ultrasonically activate my irrigant. This is the best way to do it. Now, another one question, one clinical point which I would like to share with you all here is that where should be the tip of the ultrasonic when you are activating? It should be at the coronal third, middle third, or at the apical third. Now, please remember those teeth in which we have a proper apical constriction. That means the apex is closed. Now, in such kind of teeth, you should have the endodontic ultrasonic tip 3 millimeter short of the apex. Yes, because when you activate an irrigant, the ultrasonic tip pushes 3 millimeter ahead of it. So, for example, if I have a central incisor or maybe a premolar which has a say about a length center has about a 20 millimeters, right? So, what I will like to do, if it has a well-formed cast, the tip, I will keep it at 17 millimeters, because once I have prepared. Reason being, when I'm doing the final activation of my irrigation and activating the irrigant, my irrigant tip will push it 3 millimeters ahead. Now this goes good when you have a like a closed apex, right? Now, what are the cases in which we have an open apex cases, like the immaturely formed teeth or such kind of teeth? Now, in such kind of teeth, what you should do, you should keep the ultrasonic tip at least minimum 5 to 6 millimeter short of your working length. That's the key. Because again, if you keep it again in the same way that you have keep it for the closed apex, then the chances of protruding or the pushing of the endodontic irrigant into the periapical area is much higher, and that is known as a hypochlorite accident. And if patient goes into that stage, I think it's a nightmare again to deal with it. It is manageable, but again, these are the certain tips with which you can do that. Another point which I would like to share on this slide is this: in such kind of open apex cases, how you will create the apical barrier here with the MTA. Because if it's such a wide open apex and you're putting the MTA every time, there are chances that MTA may get pushed into the periapical area, right? Now, to avoid pushing of the MTA into the periapical area, what generally I do, we have those collagen membranes. Most of us are doing implants and many other procedures. So I use a collagen membrane. I make a ball of it. Okay, I measure the working length on this radiograph, that what is the working length, and what I do, I make the ball of it, and with the help of a plugger, I will push that membrane up to the apex up to 0.5 millimeters. So that's the way. That means I'm creating a barrier for an MTA so that it doesn't get pushed inside the into the periapex, and that's what we need to maintain, right? So that's what we do. So once I have kept that collagen barrier there, so and I start putting my first increment, there you can see, you can put the collagen barrier here, and then you put the first increment of MTA. So the beauty of the collagen membranes is that they are resorbable. We are doing a lot of implants, and then we are doing a lot of bone grafting procedures in which we are placing bone grafts, and then we are placing the collagen membranes. So these membranes dissolve with time. So again, I don't have to take them out. So I will place my collagen membrane there, right at the apex. I will push my MTA, right, the first increment, so that my membrane get pushed into the periapex. But my MTA will be right at the apical one third, and that you can see here, it will help you to form a good apical barrier. So my first increment is placed, and I have achieved the three-dimensional seal. Now the next will be the second increment, that will should be, now the total increment that we should have an MTA barrier or a plug should be at least greater than 5 millimeters from the apex. That's the key. Now we need to do that. Reason being, we have lot number of lateral and accessory canals which are present in the apical one third area in the last 5 millimeters. Lateral canals, accessory canals. So we need to seal those canals for the future infections, and that can only be done in such kind of cases is with the help of an osteoinductive material, and that is what my choice is, MTA. Again, as I said, in such kind of cases, in last 5 years I have changed my protocol of working. I don't use gutta percha, I only use MTA, and that's what we have done. Like, rather than putting a gutta percha, I have sealed this canal with the complete MTA and followed by the permanent restoration. So again, what I need to do here, the main area why I'm using an MTA here is that I need to reinforce my tooth structure, which cannot be done with the gutta percha, because gutta percha takes a support from the tooth, it doesn't provide a support to the tooth. And such kind of teeth which has a wide canals, they have a tendency to get fractured with time because they become brittle. Once the root canal procedure is been done, then definitely they have chances to become brittle, and chances of fracturing of these tooth is tenfold. So I need to reinforce. So in such cases, my choice of material is again an MTA. So we have a 3-year follow-up with this. And before I come to the last part of my presentation, that is the apical surgeries again. So I would like to share a case with you on this, that how it can be done. So apical surgery under magnification, there you can see this is a case of an apical surgery in which you can see that the upper central, which has a post and core and a crown and is a metal post. So first the anesthesia has been given, right, followed by the use of the microsurgical blades from this what we have been using in our practices, so that we can raise that flap. So the incision is being given, and use of the microperiosteal elevators to raise the flap. Now the difference between the traditional microsurgery and the like traditional surgeries like episectomies and between the microsurgery is that the windows are becoming smaller now. So I will create a very small window right at that area of the root tip with the help of piezo units. You can use the round burrs as well, and we have and you can see the abscess locule. So we have tried to remove the entire epithelial lining from the walls so that we can create that area clean. And then I will make it little larger so that I can see the root tip, because I need to do the retrograde preparation. So there you can see the root tip, the root end of the upper central. So we just slice it off, right? So there is no need for bevel when you are using this piezos in this thing. The bevel is not needed in the root end tip. Now once that is been done, you can see that, and there you can see the root end being dissected, and then use of the ultrasonic tip, and there you can see the Kim ultrasonic tip. There you can see the water supply is at the tip. That's what I wanted to say. Yeah, so we have created a root end preparation so that we don't heat that area much and we don't cause any micro fractures in the root tip, followed by the irrigation. And the placement of MTA, and followed by the micro suturing. That these are the 50 sutures. The beauty is that such kind of sutures are very much appreciated by the patients because they are aesthetically pleasing. Patients are happy. Again, they are absorbable, so there's no need to come back. And then the results you can see here, the before and after, the complete sealing of the root canal system. So before, so this is where exactly I reach in the end of my presentation. What exactly where what I wanted to share with you all, and I will conclude by this slide with you that the struggle you are in today is developing the strength for tomorrow. That is important. We are in a state of pandemic, and definitely we are struggling to get back to our practices. But again, this is not the right time. Stay home, stay safe. That is the key what we are exactly looking at. And that's what we are. And secondly, what I would like to share with you all is, the more you stay at home, because the pandemic is spread all across the globe, so we have to get them down as much as possible. And you can get connected to me on my email, that is drprashant.bhasin at the rate gmail.com. You can get to our site, available on Facebook, Instagram, LinkedIn. That's the world how we are, and that's how we are being connected. So I always end by this slide in my presentation by saying that keep calm and enjoy endo. That's the key. In an endodontics, you need two things. Number one, you need to be calm and you need to enjoy it, and you need to have patience and you need to have persistence. If you have all these things with you, I think the you can enjoy what you are doing in your practices. So with this, I would like to thank each one of you for being here, and I would like to thank the forum, the platform GIS, the Global Interdisciplinary Summit, the mentors, the Star Wars, the Godfather who has been there, and to give me this opportunity to come before you and share my experiences with you all, so that we can share and learn together. Thank you so much.
Dr. Prashant, beautiful work, beautiful presentation, and amazing work. I'm
Thank you
waiting
so
for
much.
some questions, and if anyone have any questions, please start posting it, and we'll go from there. I have a few questions for you.
Yes, please.
When you're using the ultrasonic,
Yeah.
the last final before the obturation, how long do you usually keep it for? And would you like to keep it a little bit longer than just 30 seconds to a minute? Like
The last one before obturation, you can keep it up to a minute.
up to a minute.
Yeah.
And you use the non-rough tips, right? Like
Yeah,
the
non-rough tips.
smoother
Yes,
tips.
yes, yes. Non-diamond coated.
Yeah. Do you usually use only one kind of sealers, or do you like to mix and match
I
according to the
I
case?
mean, actually depends. If it's most of the time I'm using the resin sealers or the bioceramic sealers. So if I
And
have a periapical lesion, right? So in such
ultrasonic
cases,
side.
yeah, the bioceramic sealers are the better, are my choice. But rest of
Gotcha.
the normal cases, I'm in using the resin sealers.
Perfect. What's your thoughts about the new canal rotary files that are very hollow from the inside?
Yeah,
And
see,
they're the ones that I think they're just
that's you can say the self-adjusting files you're talking about,
yes,
which has a irrigant portal inside the root canal. They are, I mean, again, very beautiful, but again, that depends on the economical condition of the dentist, how they have been working at, because they are quite costly. But yes, if you ask me, anything which has a portal of irrigation through it is always better.
gotcha. And with the system B, if you're
Yes,
using system B vertical, when you transition between uh, the first device where you melt the apical canals, and then
right.
the second one where you are where using the gun.
Yeah.
A lot of times there's always a bubble in the beginning, and that's why sometimes they tell you to leave the tip there for a little bit, a few seconds, just to heat up the walls of the canals for it to slide. Is this one of the techniques that you would use, or what would you use for that?
What I use in my most of the time, I'm using actually the Optura Spartan one, right? So that is
Yeah,
from, I just say, so that's Optura 3, which I've been using in my practice. Now the beauty is, what I do is I first heat it up and I make the flow of the gutta percha outside, so that I can have a continuous flow. Because
and then afterwards, like
yeah, and then afterward you should go inside the root canal. Reason being,
perfect.
sometimes what happens, if the temperature drops down, then the gutta percha seals sets there. So again, you need to heat, and then it creates a void. So better is place it, condense, down pack, and then backfill.
One more question I think someone just posted. In
Yes.
case we need to place a post, how
Yeah.
do we go about when we fill the canal with an MTA?
Perfect. It's a very good question from, I think, Dr. Shamsia Mudin. The best way, if you have to place a post, then in such cases, what I do is I seal the canal with MTA only at the apical 1/3. That is the 5 millimeters. I close it. I send the patient back. Call him after 24 to 48 hours. Reason being, the MTA, the setting time of an MTA is about 4 hours, right? So on the same day, we cannot do a post. So you place the MTA, seal the 5 millimeter, rest, you leave it open, give a close dressing, tell the patient to go back, come after 48 hours, clean that area, prepare, and place the post.
So with an open apex, you'll do it all one time without staging it. You'll do the MTA, leave it, and then come back.
Yes, yes. If in cases
Without
of post, in case of post, if
because
I don't have to post, then I seal the whole canal with empty and go ahead with the permanent restoration.
yeah, because long time ago I used to stage it with the calcium hydroxide and then go back
Yes,
and then
yes, yes. If it's a periapical infection, then we need to heal it.
yeah. Uh, one more question, Doc. Sorry. What's your opinion about continuous
Chelation.
chelation during
Yeah,
instrumentation?
this is one of the beautiful. Actually, we should do it. We should do a continuous chelation because I also do in my practice. The most is this we do it, the better it is because it keeps cleaning of the dentinal tubules much faster. Yes,
And do you do it with the ultrasonic as well?
yes, yes, yes.
And
Activation is a key. Is a key.
with the power of the ultrasonic, what kind of you put it more towards the higher power or the weaker power, or you stage it?
I
So the
stage it.
ultrasonic,
I go with the
stage it.
slow speed because it is always better. Go with the slower speed and then increase the speed accordingly. But you don't need to go to a very high speed because the idea of an activation is that I need to activate my irrigant so that it increases the molecular energy and goes inside the dentinal tubules and cleans it well.
Perfect. Beautiful presentation. Beautiful
Thank
work.
you so much. Thank you so much.
I'm
Thank you so
looking
much.
forward to meeting you in person.
Sure.
Any
It will
more
be pleasure.
questions? Perfect.
Thank you.
I think the more
Gentlemen,
how are you, Doc? I think the more we share, the more there will be
back.
questions popping up more and more. But it's a beautiful presentation, beautiful work, and
Thank you so much.
definitely a lot of information. Very helpful. Do
Oh,
you
here's
ever
one.
sandblast the orifices before core buildup? That's a very good question. With the
Do you ever?
sandblaster,
Yeah. This is a good question.
so
Do you ever sandblast the orifice before the coat build up? It's your
essentially
choice.
the
You
sole
can do it.
trophy.
Yeah, it's your choice. But if you do a sandblasting, then I think the retention of the core material is much higher.
Yeah.
Yes.
With the salt, not
Wonderful.
sand. Yeah, perfect.
Thank you. Thank you so much.
Doctor, thank you
So,
very much.
gentlemen, again, that concludes the day. It's about 25 days into the Olympics of our profession, what we love and what we care about. Thank you for our host today for hosting two sessions, Dr. Atala, and our
Pleasure,
wonderful.
beautiful.
You have been very, very kind and supportive of the project.
Thank you.
And
Pleasure.
and our specialist here, Dr. Bhasin, who is an angel sent from up above. And what a wonderful presentation, illustrations, demonstrations. I can only, my hat's off to you. I don't have one, but
Thank you.
Next time.
Thank you. Thank you.
and thank you for
Actually, it's a pleasure for me. It's a pleasure for me. And again, I thank Dr. Kinor Shah, my friend Joseph, Dr. Arun, all the Star Wars, and like they had been the pillars for GIS. And actually, I'm honored to be on this forum, and we look forward for these sessions more in the future. Thank you so much once again to all the listeners, academicians, clinicians around the globe who actually took out their time on Sunday to actually come. The Sunday is a day to every day is a relaxing day, but on Sunday they took out time. In India, it is 12 o'clock. I can see, and people are there to listening to me. I'm so thankful to each one of you to be here. Thank you so much.
Dr. Bhasin, it was one of the most watched videos thus far that has been live, and it's on Sunday and on Mother's Day, on the same day that we have achieved our immense goal of bringing and reaching 500,000 of our peers. Let me put this one up. If you guys recall, we have our big celebration today. With that said,
Mother's Day.
500,000. We'll see you guys when we make the 1 million announcement, okay?
Hopefully 100 million soon too.
100 million.
Like it.
Well, we're going to help 100 million people.
For sure, for sure, for sure.
Doctor, it's pleasure.
Take care, guys.
Thank you so much. Take care. Thank you. Bye-bye.
Bye-bye.